webinar series. And these webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth program. These webinars are presented on the third Thursday of each month. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. From the map here, you can see my name's Lloyd Sermons. I'm the director of the Southeastern Telehealth Resource Center. We cover down in the southeastern portion of the United States, the states of Alabama, Florida, Georgia, and South Carolina. A few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. We will answer questions at the end of the presentation. So today's webinar is being recorded, and you will be able to access the webinar as well as past webinars on the National TRC YouTube channel. Like I said, my name is Lloyd Sermons. I'm the director of the Southeastern Telehealth Resource Center, and we are hosting today's webinar. Our presenter today is Suleima Salgado. She is the director of Telehealth, Telemedicine, and Rural Health Initiatives, as well as the Project Echo Manager for the Georgia Department of Public Health. And she today is going to be presenting on the capacity building through telemedicine. So Suleima, having said all that, I'm going to turn the presentation over to you.
Thank you, Lloyd. Again, I'm Suleima Salgado with the Georgia Department of Public Health. Today, I just want to talk to you a little bit about the recent developments in both telehealth and telemedicine in the state of Georgia. Let you hear a little bit about how we built our state public health infrastructure around telemedicine, kind of share with you some implementation strategies, hear a couple lessons learned, and really help you understand how we partnered with various organizations from a public health perspective across rural and urban settings in Georgia to increase access to care. We'll also have a brief discussion on reimbursement, but as we know, reimbursement is always a hot topic, and the benefits associated with telemedicine, not only for our patients, but our physicians and our payers. So again, really just wanted to give you an overview of how DPH has been structured, how we implemented a statewide telemedicine network, and then just share with you a couple of our programs. Just to give you some content, how Georgia is set up. Georgia is a decentralized state. With that being said, we have 159 county health departments, 1 county health department in every single county in the state. There's 159 county boards of health, as you can see on that map. Those 159 counties are broken up into 18 different public health districts. For each of those color-coordinated health districts, we have a health commissioner or a health director. So there's 18 district health directors. We have 1 state public health commissioner, and then we have 1 state board of public health. So you can only imagine the various layers of approval and conversations we need to have at all these levels as we, as a State Department of Public Health, work to increase access and implement telemedicine programs in these communities. We really leverage a lot of our county boards of health and our district health directors' relationships within those communities to make sure that we are implementing programs that are not only a statewide initiative, but a need in those local communities broken down by health districts. So just to give you a little bit of overview on our telemedicine network, we have a very extensive telehealth network that provides expertise statewide. Again, we have telehealth connectivity in all 159 county health departments and our specialty clinics. So we are able to connect back and forth internally from county to county. This also allows us to connect to partners and providers anywhere, whether it be patients at their home, because we've now incorporated a web-based platform for some of the services that we are currently piloting. Also with some of our hospital systems, local universities, in addition to some private practice offices. And we do this in multiple ways, and I'll get into that as we continue to expand. But again, it is one of the most robust networks that you can see through a public health department that's being led by these efforts. And that is because we made sure that we were able to connect to all 159 of our state county health departments. So to give you an understanding of what it means from a public health perspective in Georgia is patients typically come to a county health department for their telehealth visit. And in those county health departments, the nurse acts as those hands, eyes, and ears for the physicians on the other end of the screen at the distance site. We currently partner with about 40 physicians that are currently in our network for services. Again, the reason it's at 40 is because we have so many contracts internally as a state Department of Health for providers who already see a lot of our patients for services. But we also have access to over 400 more providers within the network through an agreement and partnership with the Global Partnership for Telehealth that we work with. So that's kind of an MOU we have in place as needed for specialty services and providers that we may not already have existing contracts with. Through our telemedicine program, we provide services such as TeleDentistry and various others, which I will get into. A question that is always asked is why a telehealth network through public health? And Georgia was a little unique because we received a legislative appropriation to the Department of Public Health for $2.3 million, specifically to help build on our telemedicine infrastructure through public health. The way we set up our telemedicine network initially was a hub and spoke model where we installed dedicated circuits throughout the entire state into each and every one of our county health departments and specialty clinics so that all of our sites had the adequate bandwidth necessary to support telehealth. We know that we already had some internet-based infrastructure in place for our EMRs and any other services that we provided through the health departments, but we knew that in order to provide quality telemedicine services, some of our county health departments needed added bandwidth and dedicated circuits to be able to maximize the use of the technology at their locations. As we've continued to grow and expand, it's kind of a hybrid model where we're allowed to scale up and scale down our networks as necessary in order to support telemedicine services. And that's something we're transitioning through right now is that hybrid model. Programmatic funding for us also not only came from the $2.3 million, but in addition to that, we've used and leveraged federal, state, and county dollars, as well as grants to support the expansion, to train staff, and to provide technical support. So we try to have a holistic approach and an overall kind of comprehensive approach to telemedicine for us when looking at all of our partners and all of our funding structures to make sure that every single county, regardless of what your leadership looks like, that we all work together and we can all kind of play together in the same sandbox. Many of our partnerships we also build with other state agencies within the Department of Public Health and partner agencies such as the Office of Rural Health, the Office of Medicaid, and DBHDD, Department of Behavioral Health and Disabilities. We also try to work with local universities and hospital systems. Many of our telemedicine partners, as you can see here displayed on the screen, work with us as well. And pardon me, you might hear me cough a couple times. As you can see on this screen, we partner with many other organizations, many of which I've already mentioned, for a variety of specialty services. This list constantly changes based on the community needs and demands in those local health departments and in local health centers. You will see bolded the Global Partnership for Telehealth. And again, as kind of I mentioned earlier, we have 40 agreements with various providers and agencies. But if there is a community within the state of Georgia that needs access to a specialty service through our health departments that we do not currently have an MOU with, then we reach out to the Global Partnership for Telehealth and ask them if they have a provider in their network that's willing to see patients. And that's kind of how we leverage that platform. So that really opens up the capacity for us to expand scope if we don't have existing MOUs in place with providers. How did public health get into the business of telehealth and telemedicine? Well, initially it was one of those things we like to call collaboration without boundaries, which is kind of distant learning and education and kind of just straight telehealth, just two-way video conferencing. It's kind of how we pitched it as a buy-in and collaboration within our executive leadership and throughout our state. We started looking at cost savings examples of how to build video conferencing and then expand into telemedicine without formalizing a telemedicine program initially. So as you can see in this example, we looked at a statewide conference. We knew that many of our nursing staff throughout these county health departments always have to go for routine training and professional development. And we realized that most of the time, our nurses would have to take a day or two off of work and drive to a centrally located county, such as like Macon, which is in the center of the state, and all of our nurses would have to go to that location for a 2-day training. So we took an example of one of our 2-day trainings where we partner with a local university and a training center as well as our local AHEC for CMEs and CEUs. We asked the providers were funded through this grant that we received and some funding. We thought, how cool would it be to do kind of a webinar like we're doing today with virtual registration and evaluation, have the PowerPoint slide provided virtually and or in advance for a 2-day training. Knowing that all 159 of our county health departments needed to be represented, we figured if we do this with no registration costs for our nursing staff and our customers, 500 public health nurses tuned in to watch this when we did this initial webinar of 2 days. They all received 7 hours of CEUs, which they were eligible for. And out of the 159 counties, 158 of the 159 counties participated. When we kind of factored in and did the calculations of not having to consider travel, food, or lodging for those public health nurses, it averaged at about $500 per person, which again gave us a cost savings of $250,000 for one 2-day training. Again, as we know in healthcare and as we know in any of our businesses, training is something that happens continuously. So if we multiply that by program, by the number of trainings that they have to attend a year, we were not only able to help them reduce cost on travel, we were able to help them keep their clinics open because people didn't have to commute to any of these meetings, so we didn't have to close clinics, and we were able to save dollars. So that's how we built our case for legislators to justify supporting telehealth implementation, knowing that we would then be able to use and leverage the exact same network to expand into telemedicine services. What does telemedicine look like through DPH? So it's very standard, just like any other. Our originating sites would be where our patients are located, and in this situation, 90% of the time they're in our county health departments. They have a telemedicine cart. This is just an example of one of the telemedicine solutions that we have. We have multiple depending on the clinics and where they're located and what kind of funding they had. And then our distance site is again where the physician or the practitioner is located, just like any other telemedicine consultation. People always say, why tele through DPH? And I've kind of mentioned this a couple times, but this is a good example of just the provider shortages that we face in Georgia. We were able to just pull a quick snapshot of some of the specialty services that we would refer our patients to. Well, if you look right in the middle, pediatric providers, it seems like there's a good amount of pediatric providers, but when you look at the scale, it's like 1 to 35 broken down by county. There are several counties that might only have one pediatrician. And as you can see, there's several counties that don't have any pediatricians. So when we were referring to services, we realized that a lot of our patients had to drive a significant amount of time to get to any of those services, specifically a pulmonologist, a pediatric pulmonologist, as you can see on the left, and or a dermatologist, as you can see on the right. So this was, again, one of the main reasons we decided to expand into telemedicine. Some of the specialty services that we provide through the Department of Public Health are listed as in the screen in front of you. Things such as teleaudiology, teleconcussion, a TeleDentistry program, emergency preparedness. We refer a lot of our children's medical service and pediatric patients for endocrinologist, pediatric geneticist, infectious disease, a lot of women, infants, and children services such as WIC and lactation support, mental health, nephrology, orthopedics, sickle cell, and some teletherapy. And I'll break some of these down a little bit further as we get into them. Our children's medical service is one of our most frequently used telemedicine programs. It provides care coordination to children from birth to age 21 who have disabling conditions or chronic diseases. So a lot of our clinics, such as the genetics clinic, an endocrinology clinic, a pulmonology clinic, are all pediatric clinics that we provide. And it allows our public health nurses in the communities and in these county health departments to refer patients over to those specialists without having to leave their homes. One of our patient testimonials is in the image you can see here to the right. This father would take his daughter every other week, would have to drive her 4.5 hours to get to a doctor's appointment to see her specialist in Atlanta. By implementing telemedicine, it's a 10-minute drive for him, saving him, as everyone knows, time, money, transportation, dealing with transportation issues, and allowing him still to get to work throughout the day to provide for his family. Most of our children's medical services were referring to these providers anyway for specialty services, but what we did realize, as in many other clinics, is that a lot of our patients just had trouble getting to those locations. So by implementing telemedicine as a referral source, it allows the patients to actually be seen a lot more frequently and to get the care they need without having all those barriers. We started this in fiscal year 16, and we only had 2 clinic sites where we saw about 516 patients. As of fiscal year 18, we had 8 clinic sites, and we saw 781 patients through Children's Medical Services alone. Again, the benefit for public health to do this through our CMS clinics is our CMS nurses provide that care coordination already and can assist all eligible families with any additional referral services they need, such as medications, any tests they need to do, supplies, sometimes even transportation. So as we start identifying some of the services that these patients need, our care coordination team and our Children's Medical Services program nurses can provide and facilitate this through telemedicine. Another example of how DPH is providing telemedicine services is for high-risk OB through a centering pregnancy model that we currently have in one of our health districts, where they provide high-risk OB care through telemedicine. What you didn't see on the previous map was that Georgia only has approximately 20 maternal fetal medicine specialists for the entire state. Again, for all 159 counties, there are only 20 maternal fetal medicine specialists, and most of them are in Atlanta metropolitan area, or in our Northeast Savannah Health District, Augusta, where our universities are. So again, throughout the outside coast of the state, where most of our patients would have to drive out to be able to see them. By incorporating a high-risk OB maternal fetal medicine specialist into our National Centering Pregnancy Program, it allows telemedicine for us to be able to provide ultrasounds and those maternal fetal medicine consults right in our county health departments in real time. Also allows for the same better care coordination of services. We partner with Women's Telehealth, and Dr. Ann Patterson is included and kind of rolled into the Centering Pregnancy group care model into those sessions, and she's able to discuss preterm labor, gestational diabetes, and anything else that the families want to talk about in their group setting as if she was really there. Now keep in mind that this session takes place 3.5 hours away from where Dr. Ann Patterson is, but our patients tell us that it feels like she's right there with them in real time during this conversation. Also allows Dr. Patterson and our other nurses to provide and refer for any additional services, such as cardiac or dermatology or mental health consultations for our high-risk OB women. Our Women, Infants, and Children program also benefit from the telemedicine program through the state. We utilize our platform for individual education and consultations. We also provide group nutrition services for on-demand clinics for our Women, Infants, and Children program, breastfeeding support, and lactation consultations through telemedicine. So an example of this would be if a parent comes into one of our WIC clinics and they need to see a nutritionist for special formula. Unfortunately, in some of our communities, we know that there may not be a nutritionist always available in real time for them to see. So what we would have to do then is refer our patients back for additional services or tell them to come back another day when we have that nutritionist on site. Sometimes it may even be something as simple as they need a translation and we don't have a bilingual translator available when they come at 4:30 at the end of the day for special formula. We were able to connect our telemedicine units and connect to other counties so that those patients do not get turned away and do not even have to come back for a follow-up appointment on a different day just because we don't have availability. Another unique program that we have in South Georgia is a TeleDentistry program. As we all know, tooth decay is one of the most preventable childhood chronic diseases among children. So we thought it would be cool to collaborate with our local school of dentistry in that community, a private community dentist, the local school system, our AHEC team, our state telemedicine program, the Office of Oral Health, and the local county health departments to provide school-based dental screenings, cleanings, fluoride, x-rays, and education, all via telemedicine. We're also able with our dental hygienists to provide referrals and case management for follow-up through public health. To give you an understanding of what that clinic flow and process flow looks like, this is actually done in a school system where the school is very generous and provided space for us to set up our own teledentistry suite. We collaborate with the school system, and what happens is at the beginning of the school year, all kids go home with their back to school enrollment packets, and in those packets are consent forms. Has a lot of questions and a lot of medical history is captured in those consent forms. Insurance type, do they consent? Do they have a dentist? Have they ever been seen by a dentist? The type of insurance they have, pretty much included in their back to school packet. The caregiver provides the consent. The student is called out of class and then seen during school hours in our teledentistry room. The hygienist then provides cleaning, fluoride, x-rays, and dental education in real time. The hygienist is collecting that initial information about the students, their oral health. Those images, when they're snapped in real time, they're uploaded and submitted to the dentist who is contracted for us. And from his or her office, they make a diagnosis and connect with the hygienist back to discuss the findings with the student and develop a treatment plan and follow-up if necessary. Those kids then go home at the end of the day with a documentation, whether it be in their folder or a note sent home, and a follow-up is done with the parent if necessary to let them know what happened during the session during school. Again, this is all coordinated with the school system and the school teachers to make sure the kids are being pulled out at the right time, that it's not in the middle of testing, etc. Again, this is a collaborative effort with the school. Once that's done, if there's more advanced treatment needed, the dental hygienist can then work with the case manager to begin those referrals as necessary and refer the patient to whatever type of specialist they may need for additional services. Then the results are mailed to the caregiver and or sent home in the folder, depending on the process flow at that school. And then it kind of circles around. When looking at our teledentistry clinic, since it is very unique, it's important for us to look at the overall satisfaction. It's been about 10 years since this program has been established. Again, it's mostly been grant funded year to year, but we've had overwhelmingly positive results specifically in these 4 communities. We do provide routine customer satisfaction surveys. I know it's really difficult when dealing with children, but we also ask the parents to give us their feedback and thoughts on just the overall sessions and the feedback they get from their children. We talk to the teachers, the principal, and all the other administration at the school to get their thoughts. They also normally always express a high degree of satisfaction with the program because the program is designed in a way that it makes accessing the dental care easy and convenient for the students. So anyone from the front desk clerk to the custodian, they all know about the telemedicine and teledentistry services, and they make sure that if they see any children needing to be examined, they make sure that they're referred to a teledentistry clinic. Some of our health outcomes, as we all know, is that children receive services they may not have otherwise gotten. In that local community, in this cluster where we had, there was only one pediatric dentist at the time. Then he kind of left for a little bit and came back. So it's not like we were taking away any services that were already available in this community. This was a vulnerable population that did not have true access that they needed. Also allows children to learn how to care for their teeth in a school setting. The children come to school ready to learn and experience less dental pain. Clearly, we've seen a reduction in absenteeism rates for the dental-related illnesses and appointments, and the principal shares that all the time. The parents are also very appreciative because it saves them on transportation costs, lost wages, and overall preventive care. We also make sure that we make a conscious effort as we see the children to connect them with the dental home for future services. So this is not their one-stop shop for dental care. We do make sure that they are all established and connected with the dental home for future care, which is one of the big wins for us because, again, like I mentioned, no one feels like we're taking any business away from anybody. Also, when these images are taken, if they need to be referred, those images go with the students so that they don't need to pay to have additional images taken. I just wanted to show you a little bit of data on this teledentistry program. We try to there's a lot more data that we capture other than this, but I thought it was really interesting to see the growth of the program. From where it started, from initially seeing 164 to last year, they saw 747 the year before last. Last year, we lost a dental hygienist, so the number significantly went down, but this year we're back at full capacity, so it'd be great to see the numbers again. But we do ask how many of the children have had if this is their first dental visit. We track the number that we refer to a general dentist, the number we refer to a pediatric dentist, and then we look at the type of insurance that they have. So it's really interesting to us that even though a lot of these children may have some type of insurance, they're still not receiving care if it wouldn't be for the teledentistry clinic. Another clinic we have is a pediatric and adult TB clinic because we know that tuberculosis is still an ongoing issue in our communities. Patients do come to a local health department and see the infectious disease doc who already manage their care. They're now able to do that virtually. Most patients are seen monthly, but some need to be seen more frequently due to the complexity of their care. So we've started expanding in our preventive care clinic the access to telemedicine. Again, making it a one-stop shop in that preventive care flow clinic where they're able to access those specialists without having to drive the additional 45 minutes to an hour to see those specialty providers. We've also started doing video direct observation therapy through VDOT, available to our TB patients utilizing the Telehealth network. This is where we started using our web-based solutions, where the originating site is the home. We're not billing for this service because VDOT is a required service where patients do have to take their meds and we have to watch them take their meds daily. So we've incorporated like a WebEx platform into our secure telehealth HIPAA compliant network where patients can connect and we can watch them take their therapies daily as needed, and their home is their originating site. Whereas in the past, we would have to send out a team member to the home to physically watch a patient open their mouths and take their medicine and then drive away to the next location. As you can imagine, the time, the gas, and the commitment of seeing anywhere from 2 to 50 patients taking their medication every day for an extended period of time, utilizing the telemedicine network was a no-brainer for us for video direct observation therapy. Tele-HIV is very similar to kind of what you saw before in a couple of the slides that I've mentioned before, but we're really looking at providing help to patients living with HIV who may have health barriers to overcome in receiving treatment. Again, this is for urban and rural settings, and we know that they deal with issues just like everyone else with transportation, stigma, work schedules, provider shortages, and the distance to provider, and long waits for appointments. So we set it up very similar to our TeleDentistry service, where the patient presents at a health department and is received by a public health nurse. We connect with a remote infectious disease doctor, and then we go back with our public health nurse to discuss the further recommendations and follow-up treatment. We are getting into teleprep services where the home will be an originating site as well, but we are testing through that right now and looking at what the reimbursement models are for that in the state of Georgia. So we should have data on that pretty soon. When talking about requirements in Georgia, again, approved originating sites in Georgia only are the office of a physician or practitioner, hospital, rural health clinics, a federally qualified health center, local education authorities or school-based clinics, county boards of health, emergency service ambulances, and pharmacies. So again, public health sites are considered originating sites, and this is kind of where we started implementing most of our services. Again, we thought public health departments would be a great way for us to present patients because 90% of public county health departments are centrally located in these communities. They're on a bus transportation, they're on a shuttle service, you can access them and they're centrally located, making it a lot easier for these patients to get there. Why we'd like to see a lot more home services, the bandwidth capacity is just not there in some of these rural communities, even if we were able to use the home as an originating site. There are a lot of barriers that we're still facing there. From a Medicaid perspective in Georgia, we're able to bill a $20.52 fee per encounter for Medicaid, which is great. I know it's not a lot, but anything is better than nothing, and we're really appreciative of that. We've also worked with a lot of private payer sources to allow telemedicine to be a modality. So based on that payer, we are able to also recoup a fee. From a distant site, we've also looked at that from a physician perspective, and you can see on the screen what is allowed from a distant site provider and who can be a distant site and bill for services in Georgia. There's one thing I do want to talk about, and it's a new initiative that we have. Not only are we providing telehealth video conferencing and distant learning and education, we're also expanding into telemedicine services, as you've seen there. We have a new DPH infectious disease ECHO program. And Project ECHO, for many of you who have or have not heard of it, is a lifelong learning and kind of guided practice model that kind of is intended for medical education and to exponentially increase workforce capacity. So where telemedicine looks like it is patient to provider, this is kind of peer-to-peer model. So the heart of the ECHO model is a hub and spoke knowledge sharing network. So it's kind of distant learning at its finest, but it's medical expertise from multi-point videos to conduct back and forth virtual education with other community providers. So really increasing that workforce capacity and provider capacity in these communities where primary care doctors, nurses, and other clinicians provide specialty care back and forth within their own communities, but kind of build capacity within those communities. So a general practice doctor can really reach out to an infectious disease doctor and become a lot more familiar with what is necessary to treat patients in their community, even though they might not have an ID expertise. You can kind of see it here on this slide is kind of where I'm talking about peer-to-peer versus patient-to-peer. This is one-to-many. So the patient for telemedicine is kind of what you see on the left. But Project Echo is really more acquired knowledge where people can treat more patients, build community and practice, which will allow in turn for all of our communities to reduce health disparities, retain local providers who may not have access to them, and increase the overall community quality and access to care. So Georgia Department of Public Health has implemented this year our first Project Echo specifically on infectious disease. And those are now monthly infectious disease sessions where they're hosted very similar to today on various topics specific to ID. We started, I think, with 8 participants. We've grown to at least 58 continuous, and we have about 185 registered ECHO participants in just a couple of months, as you can see. Anyone is invited to join the Georgia Department of Public Health ECHO ID ECHO. You can email the georgiadph.echo@gmail.com, and we can add you to this ECHO and be part of the conversation. Some of the challenges and barriers that we have faced in implementing telemedicine in Georgia is very similar to many other states. Reimbursement has always been the largest barrier. Medicare has restrictions on reimbursing, obviously, of the locations, the types of providers, and that's always a barrier that we're dealing with. But as it relates to Medicaid, I know it varies state by state, but in Georgia, Medicaid is very supportive of telemedicine expansion. We have worked with them closely on several of these pilots, and for them, the partnership has been integral for us. Having Medicaid in the same building as the Department of Public Health allows us to kind of just go up the elevator a couple floors and sit down and have conversations with them before implementing programs and really sharing them our thought process behind these programs. Medicaid has been great at kind of sitting there with us at the table, present, helping us build the program, doing a couple feasibility studies and very targeted communities. And once they can see that return on investment and see the impact that we made, they've been very supportive of opening codes for us. For private payers, they vary very widely. It's hit or miss, but as usual, they are pretty open to telemedicine. But also the really interesting thing about reimbursement is telehealth is usually reimbursed at a lower rate. Fortunately for us in Georgia, last legislative session, we passed a bill that now allows telehealth to be billed at the same rate for all other services, which is going to be a huge change for us come January in Georgia. So telehealth services and telemedicine will be billed at the exact same rate as an in-person, which is going to be great. Interoperability is always one thing. Ensuring the platforms across agencies and systems can share information is key. While our platform and infrastructure is very heavy in Cisco-based solutions for Georgia Department of Public Health, we do have opportunity within our platform to open to other platforms and exchange and share. So regardless of the platform that others are in, our tech team has made sure that we can access and connect to other platforms. So if people are on other networks, they have other platforms, whether it's a Cisco product or anything else, we are able to work with the other agencies and hospital systems and different platforms to make sure that we can all connect and still provide care without having to change the infrastructure on the distant site. As usual, provider availability, just because we have this really cool, robust network, there's still a huge limited number of specialty providers in the state who can actually provide care. Again, this might change this upcoming year with new legislation that Georgia passed, allowing specialty telemedicine licenses to take place. The Georgia Medical Composite Board will now be issuing telemedicine licenses for providers outside the state of Georgia to see patients in Georgia. So I really hope to kind of see what that looks like for us moving forward and what kind of access we'll have to additional providers to see a lot of our patients, specifically for specialty services. Infrastructure is always an issue. I know that it is 2019, but bandwidth in rural Georgia still is an issue, not only from availability, but also affordability. When looking at our bandwidth and having our dedicated circuits, even we from a Department of Public Health struggle to look and make a cost savings method to utilize. I know it's $2.3 million, but that goes very quickly when your circuit costs range anywhere from $150 a month to $2,000 a month, depending on what provider is available and if there's only one provider in certain communities. So affordability of infrastructure bandwidth is really huge for us in Georgia. Metropolitan area, not so much, but a lot of our rural communities, there might even still be a couple that are on dial-up. So trying to implement telemedicine in one of those communities is very difficult. So just imagine being able to trying to expand that not only in a health department, but taking that into a home, it's nearly impossible. Funding is always an issue. I know anybody doing telemedicine knows that funding is an issue. While it's not as difficult to secure funding for one-time expenses such as platforms or carts or different solutions, sustainability funding is always hard for us. I'm really looking at how can we make this sustainable without reimbursement and or with very little reimbursement. So we're always looking at challenging our leadership to look at funding opportunities, whether it be leveraging existing grant and aid dollars that go to the health departments and local communities for services, and tapping into all of our programs, local programs who might impact and implement services in local communities. So our state oral health program may contribute to a telemedicine program in a different county and tell them that they're able to utilize their oral health grant and aid for telemedicine services. We also that make sure that as a state, when we're applying for grants, that we always incorporate a telemedicine component, since all of our programs throughout the state are able to utilize the telehealth platform at any of their sites for any services they need to connect. So with that, I'm going to pause for questions. I know there are probably quite a few, and then we'll have a couple more times for just more discussion. So give me just a second. I'll look to the right. Lloyd, if you want to help guide any. I do see one question that came. Do you ever see the patient where the originating site is their home? So yes, to answer that, we have been able to do that question. To answer that, we do have 2 home health services right now. So we do provide VDOT in the home where the originating site is the home. We also are doing some speech therapy and audiology services via telemedicine where that presenting site is the home. Again, that is for a very specific Medicaid population, but Medicaid has open codes just this year for us to allow the originating site to be their home. So yes, again, this is kind of not really a trial, but this will be our first kind of true implementation where we're able to measure success, look at quality of bandwidth, look at connectivity, look at health outcomes. So yes, we're getting there. Second question. Are all sites able to connect between each other? Is there a need to be the same video conferencing software, or can one site or center or hospital with a video conferencing software be different from other sites? So yes, again, I mentioned we are very Cisco based in our infrastructure, our network, and all our connectivity is Cisco based. But since we have so many providers and other networks, even just with the global partnership for telehealth, our local hospitals might have other telemedicine platforms. Our IT team does everything possible to let everybody come as they are, as long as they meet certain parameters, and we were able to integrate together to provide services. So yes, there doesn't need to be the same video conferencing per se. All of our sites have the same platform. They might have different brands of it, but they're all shared and connected. But if we have an external partner coming to the table, they are allowed to utilize a different video conferencing software, as long as they're able to meet our kind of come as you are parameters. We don't change and go to use a different platform, but we do allow for other platforms to join us. Hope that answers that. Next question, are you able to do STD testing and treatment through telemedicine? We are slowly working on rolling that out right now, specifically even through like PrEP and issuing medications. Some STD testing and treatment can be done via telemedicine, but it's really limited. A lot of that might be done in person, and then follow-up will be done via telemedicine. Where are the records kept? So since most of these services are for existing public health patients that may come in for services, we keep those medical records on file. When we are working with an external provider, though, let's say a geneticist or a pulmonologist from an outside provider such as Children's Healthcare of Atlanta or Augusta University, we keep consent form and a one-page medical history of the service that was provided in our health department clinic, but those records are then sent back to that medical facility and they store them at their site. So small scale record keeping on our end, but the distant site and that provider keeps their medical records as well. That is kind of one of the issues we still face when it comes to exchanging and EMRs, is every single county health department might have a different EMR. So from a telemedicine program perspective, we don't keep any of that data, but we do help the programs in the counties work together with those providers to keep those records and make sure that they are consistent. So we don't have a centralized EHR in Georgia. It's in the works. I don't know how long it will be, but everybody kind of has their own platform, and we kind of work around that and modify it as necessary. We also kind of do those one-pagers, as I mentioned, and then they're able to upload those, send them electronically via encrypted email. Some still actually scan and fax, which is kind of creepy, but it works in some of these communities because that's the only option they have. How can a PEDS primary provider refer a patient to see these specialists? So if you're in Georgia and you are a PEDS primary provider, you are happy to reach out to myself at the Department of Public Health and we can connect you. You can also reach out to Lloyd and team or the Global Partnership for Telehealth to see what what specialty services are available and to get your patient seen through them, especially if they're eligible for public health services for some of those specialty clinics. We work very closely together in Georgia with a lot of the school-based health centers and the other sites at the Global Partnership for Telehealth to make sure that everybody's being referred to as necessary. So yes, anyone can access those services through public health. How do you market this program to the patient community? It's a great question. That's kind of one of our new initiatives from a state telemedicine program. Again, my role is to help implement and establish programs at the state level, but really where the work gets done is in the local communities. Our team provides technical support, our team troubleshoots, our team helps schedule clinic and provide the implementation, but really the local county health departments are the ones that push the marketing to their patients in the community. However, this year we are making a conscious effort to come up with a kind of integrated marketing plan, not only for providers, as the question was mentioned earlier, but for the community to know that a local public health department is a great presenting site for some of these specialty services. We're also just working with legislators now to make sure that health departments can be presenting sites for not only existing public health patients, but for anyone that might need to be connected to an external site. And that is something that's in deep discussion right now. But the marketing is pretty much done word of mouth as you come into the health department. If you are seen, normally we would refer you to a service, but our public health nurses are now saying, hey, you can either go in person, but telemedicine is also available to you for this specialist and for this service. Would you like to test it out? So it's really more once you're in our system, we refer you to those services via telemedicine. But again, there will be a bigger push this upcoming year to expand it and make it more of a public campaign. I think that is the last question I see right at the moment. I'll pause a little bit and see. Thanks for the comment. Appreciate that. Any other questions?
Thank you so much, Suleima, and great presentation, as one person commented there. Just so you know, our next webinar will, as I said earlier, these webinars occurs every third Thursday of the month. So you can see here, Thursday, November the 21st will be our next webinar, Redesigning Care in a Series-Based Care, OB and Autism Caregiving Training. So make sure you mark your calendars for that. You can check out telehealthresourcecenter.org for more information there. We value your opinion and ask that you take a few minutes and complete the online survey that you'll receive. If you'll help us out, we appreciate greatly the feedback there. Thank you and have a wonderful day. Thank you, Suleima.
Thank you, everyone. Y'all have a great day.